Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is SeamlessMD's CEO, Dr. Joshua Liu. Today we're joined by Dr. Romil Chadha, the CMIO at UK HealthCare. Dr. Chadha, Romil, welcome to the show.
Thank you, Alan, and thank you, Joshua, for the opportunity. Always a pleasure. I have listened to many podcasts and I follow Joshua on Twitter as well as on LinkedIn more often and find his posts very insightful. So I'm really thankful for the opportunity.
That's so kind of you to say, Romil. Thank you. And we're excited to have you on the pod today.
Yeah, it is our opportunity to have you on today. Josh is very active online, but you are certainly the expert here today. So I'm so grateful to have you on the show. I've heard early on you chose hospital medicine as your career for the immediate gratification of helping patients. And I'm curious, even before that, what drew you to healthcare in the first place?
So I grew up in northern India, largest state of India, Uttar Pradesh, and my dad practiced rural medicine for close to 35 years. And in his late career, he was advisor to the Director General for the whole state and was like a chief medical officer for a population of 1 million, 2 million cities kind of thing. So like the population of city would be 1 million or 2 million and acting as a CMO for all the healthcare services. So I saw that pretty attractive. At the same time, the computer science, and I don't think both of you would be old enough to remember GW Basic or Turbo Pascal or Fortran. So I got introduced to that programming pretty early on. So the healthcare and engineering side, and I was pretty conflicted. What should I do? Should I become a physician? Should I become an engineer? And those were the two options or two streams which I liked, and drifted more towards the life sciences and biology and became a physician. Early on, I wanted to be a hematologist oncologist. So I worked in MD Anderson Cancer Center, was a research assistant, did work there, phenomenal mentors, did a residency. In residency, couple things happened. I realized that I'm such an impatient person that clinic and long-term follow-up would not be suitable. I didn't like procedures a lot or blood a lot, so kind of the options were limited. So I introduced myself to my patients as no needle, no blade doctor. And that's how the hospital medicine and early gratification of inpatient medicine came through.
Oh, that's wonderful.
That's amazing. I was going to say, so did the informatics thing come quickly to you, or was that later on your journey?
So I was trying to find a niche area after I joined as an attending at UK Healthcare. And I would give the credit to the two prior CMIOs, Dr. Carol Steltenkamp, who was CMIO for UK Healthcare and was very active in HIMSS and one of the leading women CMIOs of the country at that time, and then Phil Bernard. So I met with both of them early in my career, and they suggested to get involved, and that programming and the neural pathways which were built in already, and they kind of rekindled that passion towards the informatics side.
Amazing. I think a lot of folks we've talked to have shared how mentors have played a crucial role in shaping their journey. And a lot of it's like very accidental, like by chance, whoever your mentor is early on ends up defining your career in so many ways. So it's a lot of serendipity involved, it sounds like.
It is. And a movement in doing something and then the other and then the other. Kind of like the diverse or variety of experiences. I still remember Carol Steltenkamp, when I went to her close to 13, 14 years ago, she said, Romil, if you are interested in informatics, do business and informatics. So I ended up doing an MBA also on the way.
Do you feel like an MBA has made you a better CMIO?
I would say yes, because the business side, the marketing side, the selling, the economics, or the social science aspect of leading people, it's not informatics in these days have a lot of leadership skills and things involved, but the MBA takes it to a different side.
Yeah.
Oh, sorry, go ahead, Alan.
Well, I was just going to say, speaking of the business of medicine and incorporating that into how you're thinking about informatics, throughout all of the accomplishments that you've had so far, I'm really curious to understand, what is your strategy or your playbook, maybe 1 to 2 strategies you found to be particularly effective in helping others adopt new technology and new interventions, new innovations? What's your methodology around that?
So, Alan, over the years, I have to find what is my go-to source. So one of the podcast, Hidden Brain, became my go-to source because a lot of science, engineering, or medicine literature, we are used to. But the social science part, we are not used to. And humans are driven by behavior or social science a lot. So those were my weak areas. So I tried to improve them. As a left brain person, the right brain side of the art or the social science is always lacking. So that was the area. I tried to develop couple like the broken leg rules or trying to bring some questions to binary thing. One of my famous thing which I use as a strategy when the end user or a group comes to me is, can you do it on paper? Everyone starts, a problem comes and EHR or electronic solution is the first knee-jerk reflex. And asking a person, can you do it on paper, just gives them an idea. What would be the process like? Who do they have to engage? Have they thought of it as a business plan or a project? Who are the stakeholders? Who are getting impacted? How are we going to communicate, kind of thing? So that becomes my first question. And many people joke around in our organization and my friends that, has Romil asked that question already or not, kind of thing. So it also keeps us nimble towards the downtime, which are like a reality. A downtime or a cybersecurity impact or something or the other is going to continue. So we can't just burn all the paper, but at the same time, we have to design things on paper to bring it to electronic form.
Do you find that sometimes when you ask folks to try solving on paper first, they go back and maybe they end up realizing, actually, I don't need technology to even solve the problem?
Yes, yeah. So, and that's what the famous irony of US healthcare thinks, maybe, that yes, out of 20% GDP of a large economy, maybe 10% of the whole healthcare GDP is fraud, but we have created 20% administrative burden to solve that 10% problem.
It's funny.
Today's episode is brought to you by SeamlessMD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. You know, we give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what SeamlessMD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. SeamlessMD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, you know, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50+ out-of-the-box care plans available today on SeamlessMD. Go to www.seamless.md. That's www.seamless.md to learn more.
You know, you talked about the idea of, maybe we still need to have paper for certain situations. And of course, with the growth of AI and excitement around it, especially around, generative the last couple of years, there's a lot of talk obviously about how do we not only go from paper to electronic, but maybe to accelerate electronic with automation like ambient and some other things. So Al and I are always curious, talking to leaders like yourself, are there certain AI categories in healthcare that you're most excited by? And are there others that you're kind of more cautious, you think are overhyped?
This goes back to Alan's prior question, and this is another strategy which I end up using. And the author, Daniel Kahneman and Amos Tversky, about the Thinking Fast and Slow book and behavioral economics comes into play here. When we are thinking of solution, are we thinking of friction or automation? Because if it is a system one thing, that it should be knee-jerk. A patient who has a wound needs a wound care consult. A person who has a mobility issue needs a physical therapy, occupational therapy kind of thing. A person who's having difficulty in swallow, we need swallow evaluation for those patients. So those are automated things. A person with organism history of a bacterial infection needs contact precautions. So these are all automation. If we are putting that in bucket of a nurse or a physician or putting friction, we just don't like our colleagues. Other side is we need a cognitive step. We are dealing with low therapeutic index medications, maybe amiodarone, maybe lithium, maybe something else. And that's where we need the right amount of friction so that we give that cognitive pause to the person. So going back to this philosophy, first figure out whether it's a value-added thing or not. And second, does it need a cognitive step, a friction, or does it need automation? And all those automation, people, physician groups specifically, or APPs, if they find some task non-value added, and we can go to the automation side on there, it does not need a friction step, that's the perfect for AI. Two other books in this area, one would be from Bob Sutton and Hughie Rao, The Friction Project. And the other one is from Kellogg's professors, I forget their names, but the element of choice. And they talk about 4 frictions in that. So all these things are defining what is friction, if it's needed or not. And I would say that that is the part in AI which we need to be adopting as well as rejecting.
I love that because it gives a very clear framework for the colleagues that you work with to understand, okay, if you're going to come to the table with a use case, like let's actually have an approach to figuring out, should it have a cognitive step or not? Should there be more friction or less? And then also helps them understand why or why not it makes sense for UK to automate or not automate. That makes a ton of sense.
So I'm curious, Romil, with any AI initiative, sometimes there are loose KPIs associated with it if it's not immediately evident that it's going to be helping. I'm curious which KPIs you're keeping a close eye on today with all the AI initiatives that are running around.
Alan, I have a bad reputation about going on tangents. So I will start with a tangent here. My mom brought me up with a saying, and that saying is in Hindi, but basically it loosely translates to, if someone tells you that the crow bit your ear off, you have 2 options. Run after the crow or just look at your ear. You can feel it, right? You can find out if it was bitten or not. So that is the state of KPIs in healthcare. A lot of things have been imposed by the policymakers, the insurance payer industry, or as a risk from the malpractice industry. We can challenge some of the widely adopted ones like readmission rates and some literature that in heart failure patients or in pneumonia patients, it actually may be increasing mortality to have a lower readmission rate. Similarly, I have become very kind of paranoid about just following a metric or a KPI strictly without knowing. At the same time, the ones which I believe are patient experience. Patient experience has had ups and downs, but I find it very valuable. That would it add better experience, better value for my patient or not? And similar analogy side on the provider and the physician APPs, healthcare workers, nursing, is their well-being. If we don't take care of these 2 populations, which is the patient and the healthcare workers, we are just going to go in the place where we are creating metrics and driven which are not proven in real life and doesn't have much evidence behind it.
I wonder, as I say it out loud, I think I might laugh myself, but do you ever imagine like an organization could just run on those two metrics and be highly successful? It feels like too few, but I'm curious.
Yeah. It feels like too few. We had a guest speaker and a visiting professor, Tate Shamfeld from Stanford, who has done a lot of work on the engagement and the physician nurses burnout and things. And I asked him the same question. And there are not many organizations which will let go of their traditional metrics. But at the same time, from social science or organizational economics or psychology, there is enough evidence that the employee engagement is one of the best predictor of the health of organization. And actually, there was a Hidden Brain episode just within last month about that.
Amazing. Actually, as we talk about it, I think you could maybe run an organization on just patient experience and staff well-being if you have a great culture where your staff, you don't have to ask them to care about mortality. It's just inherent in them to care about the outcome and making sure patients get great care. I think if that's just part of the culture, then you don't have to even measure some of those metrics because you know that they're going to take care of things themselves. If you have a bad culture where staff are like, oh, great, I'm just going to work 2 hours a day and my well-being will be great, it's probably not going to work well for patient care. So the culture really matters.
Totally. Another use case from just this conversation, Joshua, is a lot of things which we believe have correlation or causality may be just variation of data on time period. So longitudinally, if we are able to get 50 years, 20 years, 30 years of data, whether these things are important or not, that's another like a big data sets or a large language model or AI use case towards the analytics side.
So actually that raises an interesting question. So for example, you take something like Ambien, like the AI scribes right now, and I know there's a lot of excitement around it, and I've definitely heard there are at least some clinicians who rave about it, and they feel like their well-being is much, much better. But to your point, if let's say you played out in 30 years' time, will there be some long-term or second-order effects we didn't think about that maybe we need to resolve? So for example, to your point earlier, like if the less that you have to be involved in making a note, you lose some skill with the automation. Whether if there's a cybersecurity attack or something else where you wish you could go back and have those skills around constructing notes. Like I wonder 20 years from now, when we have lost something, when we don't make our own notes anymore, maybe we'll have replaced that with something better in terms of we're spending our time now on other things in patient care that we're happy with that trade-up. I don't know, but I'm curious what the 20-year outcome might look like, and maybe we'll have some regrets or maybe not.
I'm ambivalent on that, Joshua. The reason is that not many humans do farming or hunting, gathering stuff today. And the reason is that we don't need those skills. I will never teach my son or daughter to go till land. I never did it myself, actually. So how can I? But at the same time, not knowing for certain things could be dangerous. And that's where probably the impact in medicine would be that how do you train if everything's answer is going to ask a chatbot? Do you, like the Johari's window, what we don't know kind of thing would come into place, that then the obsolete part for the healthcare would be the assumption of risk also. So who will be assuming the risk? Because a lot of industry is dependent upon the risk. Who is it attributed to?
It's a great point. And I think one of the things that's definitely played out, your comment about the hunter and gather is a good one. I mean, there are obviously folks in the world who still hunt and gather, or at least, they're responsible for agriculture and food and resources, but everything's becoming more specialized. So like that industry is specialized. There are folks who do that, but they don't practice medicine, and you practice medicine, but you don't do, hunting and gathering and acquiring food resources. So it makes you wonder though, as AI gets more involved, even in healthcare, maybe clinicians will specialize even more and more and more. And there'll be a portion that they start the experts in, but it's maybe very different than what they're doing today. I don't know.
Yeah, I don't know. And some of them are skills and some of them is like acquiring knowledge. And maybe that's a bifurcation, because if the writing goes away, which it is going away, that was a skill which typing can almost replace one-to-one. There is an art in that. There is calligraphic and thing. But at the same time, the phonetics, which is the spellings, that will also go away sometime, because like once the kids are more and more onto the word processors, it will automatically give them the right thing. The next things would be books, and that would be dangerous. Mustafa Soleimani's his TED talk on the AI, it talks about how one person in their lifetime is going to just read, if they're reading every hour, 8 billion words, while a large language model can do that in a month kind of thing, and just one model. So yes, it would be more productive to ask the question to a chatbot, but will the person know the difference, that is it the right answer or wrong answer? Where is the value for that? And I think dexterity skills or mechanical skills versus cognitive skills, these are the two things. And that's where the question, like actually the evidence from Daniel Pink's work of autonomy, mastery, purpose can come into the same philosophy, that for high cognitive tasks, if we attach incentive or disincentive, people perform poorly, versus if it's purely mechanical task, then our performance actually increases on carrot and the stick.
It sounds like from what you've described, what I think we're going to see, which we're already seeing, is for some of the, let's call it, low cognitive things around, let's say, using AI to summarize information. It's going to be very common for clinicians to say, hey, AI, can you summarize, parts of this publication for me? But the actual thinking, the interpretation of the information, at least for now, I want to use my own brain to think about it, but accelerate the process by summarizing the data for me or the information. That co-pilot piece sounds like, at the very least, that's something that's going to happen and work pretty well in medicine.
More pretty well than that. Yeah. Another challenge which we were discussing actually within our, I have two phenomenal ACMIOs for inpatient and ambulatory, Dr. Joseph Bobadilla and Brian Rohn. And we were just discussing, and my radiology informatics medical director, Dr. Stephen Hobbs, we were just discussing yesterday that more and more ambient listening based things are going a little backwards, because they are converting the smart forms macros, which is more discrete data, to more free text also. So unless we have analytical abilities on the downstream for a decent amount of time period, we will be taking a little U-turn in the data gathering and data validity actually.
Just to make sure that we understand, would it be, for example, if someone used an acronym and you might, for example, let's say someone's short of breath, you might have, I know the term's not great, but like an SOB in the document, but at least that phrase is common, the acronym is used, you can tag it later for analytics. But if, for example, the LLM changed it to, they had trouble breathing or something that was, not a common acronym, that might hurt the downstream analytics, perhaps? Is that a good example, or is there a different example you would use?
As well as those check marks or tick marks, or like the macros that this is normal temperature or abnormal, like fever, normal breathing or abnormal. So like that data point become discrete data point in EHR's records, while a free text is like more variable. You have to go to the NLP or the large language model to interpret that. And till that analytics comes in integrated in EHRs, we are losing some form of discreteness in the data.
Yes. Unless you go back and edit the node and add the discreteness. I gotcha.
Right. Or eventually have the AI fill in a discrete field again, kind of going backwards.
Which is probably, you expect that should happen. That should be the path there.
Yeah, but in the meantime, a little U-turn in the meantime. Very interesting. So I'm curious, Romil, there's two topics that you mentioned just now. One was around incentives and disincentives. And I'm curious, when you're implementing a new technology or even a non-technology solution, what are the steps that you're taking to evaluate the various incentives and disincentives that are at play?
So we have a very robust governance methodology, which involves kind of a triad plus technology kind of stuff. So we have physician or APP clinical leader side. We have operations, nursing leader side. So these becomes kind of a three triad, and with them paired is IT, informatics, and things. So then there becomes a process of governance or business case in the sense that what are we doing? Ultimately, the last part comes is our cybersecurity risk, basically. So the IT risks and the legality. So those are kind of different elements. Those are at large level how the processes or decisions happen. At an individual or local level, personally, I'm not the biggest fan of incentive, disincentive for cognitive tasks.
Yeah.
But if it's a more mechanical task, yes, they can work. And another philosophy which I have developed over years is, if you want to destroy a process, attach money to it. And once we do that, people's behavior will change and they will try to game the system. And the things happen. Like we don't intend to do 95% of people just want to do the right thing till we attach money to it. Once we attach the money, then human behavior changes drastically.
Yeah.
So I shy away from any attaching money to the incentives, disincentives, the autonomy, mastery, purpose, internal motivation. If I can get that, I will take that any day over incentive, disincentive scheme.
So I guess internally, like when you're rolling out a new technology or new innovation, is it fair to say, though, that generally speaking, it's hard to, you can't generally use monetary incentives for most things internally anyways, I'm guessing, right? So that means that when you're rolling out something new that you're trying to get adoption from, you're somehow trying to attach, like if you're trying to encourage your physicians to use a new item in the EHR or follow a new best practice, you have to align it somehow with something else, whether it's mastery or autonomy or something else. Is that
something of value kind of thing?
Yeah.
Just giving example, in-basket messages are a big issue for people, and specifically in the ambulatory and the primary care space. So I went to a specialty group yesterday and I did a demo and showed them the profile of a generalist, someone in family medicine or internal medicine, and tried to show them that how this person is making their life better with this tool. You want to adopt it to make your life better, do it. Just to improve the metric, nah, leave it.
It's fascinating. It's like when someone decides to do something new, the metric might be a way to measure whether it's working, but that's not why they decided to do
Why
something.
did they do something?
There's like an end goal or a piece of value that they want to achieve. For example, it might, to your point, might be like, let's say there's a new tool that reduces the in-basket number of alerts. The goal for them isn't necessarily to get less in-basket alerts. That might be a leading indicator. The goal might be, I want to spend more time with my family.
Yeah.
And that's not a KPI that you would have, at UKY, but that is why they want to maybe adopt this intervention.
Technology, exactly.
Right.
To get the time back. There is no doubt in certain things, which is, has EHR taken time off physicians, APPs, nurses, pharmacists? Yes. Can we get that time back? Can we move that non-value added automation part, which does not need friction, to the AI part, to the part of technology? Yes, those should be our answers, and that's how we should be evaluating the technology.
Can I ask you, so like right now, because a lot of health systems, the finances are still very, very tight. So whenever something new is coming in, there's always this conversation about, well, what's the ROI? What's the ROI? And there are some interventions where it may be hard to have a quantitative ROI. So for example, if we're talking about freeing up time so that well-being is better, so staff can spend more time with family, that doesn't have the same quantitative ROI as this is how many, how much more revenue we generated this year, or how much in cost we saved. So how does someone make the pitch to your leadership team around ROI when maybe some of the metrics might be a little bit fuzzier, like, spending more time with family, perhaps?
That's where the vision of leadership comes in. The people I report to, the people who are in executive positions, and for them to understand that, yes, for some things, we may be able to develop process KPIs, but we will not be able to develop complete outcomes. Then we try to measure something like well-being based on some of the burnout indices kind of thing, and then attach those to the loss of physician workforce and things like that. So we can use some examples and into those sense, connecting those two things. And that's where the discount factor comes in, whether we are able to sell it and whether the leaders are able to discount less and assume that all of it is going to work. And that's what makes a good CEO or a good leader in that sense.
That makes sense. Can I ask you, so, once a new intervention or tool has been rolled out, and let's say you've measured the results, it's been successful, it's been sustained for some time, is there a time point in the future where you just stop measuring the metrics because it's been there so long, you believe the success, it's actually not worth the resources to keep measuring those KPIs for that intervention or that tool, and those resources should go to something new? How do you think about when you stop, measuring some of the data?
That's a good question. I've never been kind of exposed to that area yet. I would say that in my chief of hospital medicine role, I did do that. We measured that for individual people, but once we were able to demonstrate as a cohort that we are able to achieve that, then it became an information for self-improvement rather than a target. So we still measured it, but our messaging changed from target to this is for my performance improvement, that how many, if you believe that you are seeing sicker patient and spending time, what is your distribution of level 1, 2, 3 and things like that. More informational, self-improvement growth rather than a carrot and a stick.
I think I've seen you've written before that the idea that I think once a measure becomes a target, it's no longer a good metric. Do you mind unpacking that concept a little bit more for listeners?
So this is Goodhart law, a British economist, Goodhart, who proposed that when a measure becomes a target, it ceases to be a good measure. And we can use some example from Cobra law, which is during British Raj in India, in New Delhi, there was huge population of cobras, snake. And they thought, okay, let's make use of the native folks there and we can ask them to bring dead cobras they will kill the cobras and our population will decrease. What actually happened was the population increased because people started to breed cobras to kill them and make it as a money-making business. So what people will do is very difficult. Many people have worked on that. Maslow's hierarchy, that we have some different needs. Our self-actualization, belonging needs are bigger, but they will only come when we have physiological and psychological safety. Leon Festinger's work of cognitive dissonance, no one wants to see themselves as I am a bad person. So they will change the narrative or try to do the thing which will cause least cognitive dissonance. Daniel Pink's work on this. So all of them have very good connection that, yes, we can make metrics a target, but when we do that, the human mind will continue to justify some things more than the others. And people want to do the right thing. Whenever we are trying to think that people are thieves or they are trying to do something bad, we are just wrong. I think policymakers should stop thinking about that. I think the payer industry should stop thinking about that. Most people come to work to do good things, right thing. And developing measures or targets in a way to prove that person is stealing less, not right. Just not right.
It's almost like sometimes this is why, having a good process and getting the team bought into the right process and they believing that if we do the process right, we'll get a good outcome may sometimes be better than just trying to have a target, because to your point, people might take all kinds of paths to get to the target, some of which may be good, some of which may be things that we don't want to happen at all.
Yeah. And in the medicine literature, we have seen that. The tight control of blood pressure, the tight control of diabetes, like the blood sugars. We have seen all these things, that how what we believed at one time is not accurate.
It's tough because at the same time, though, as a leader, you often feel as if there have to be some targets, some goals, and then you'd be very thoughtful about, well, what are the right ones then that don't incentivize, bad behavior
Group target. I think a group target is another thing which creates collegiality, camaraderie, and a true north kind of thing. But once we start moving those targets for individual people or smaller groups, then it becomes more difficult. So we cannot deny that as a country, in some metrics, we are behind European countries and we are better than some of the African or Asian countries. There is no doubt about those things. But when we try to tie that up to a city, county, hospital, few group of people working in that, then it becomes very difficult.
Definitely.
So, Romil, actually, speaking of collegiality, I was curious. I know that you've been a big proponent of creating this burnout-proof culture, and obviously that sounds amazing. And so I'm curious, what are some of the strategies that you've actually found to be effective in creating a better well-being for your staff and having less burnout in the workforce?
My philosophy around that is from work of Daniel Gilbert and his book Stumbling on Happiness, that more choices usually lead to more frustration and unhappiness. So one of the strategy which I have used in the usability side or clinical decision support or order entry or other things is to ask, do we need to create more choices or limit choices? And that again goes back into the side of, because if we create more choices, we have created more friction. If we limit choices, we are kind of creating more automation. So based on the problem, is that needed or not? And thinking of the user, basically. So all those things have to be designed in a way that we are cutting down inefficiencies for user, what they want to do. In other words, what our CDS is, making the right thing easy kind of thing. So those will be my philosophies. And feedback. How many times organizations are able to get that user feedback? Another thing would be the campaign from Hawaii Pacific, Gross, Get Rid of Stupid Stuff, which was very popular. It got published in New England Journal of Medicine about the methods they used to cut down the hospital medicine, Journal of Hospital Medicine's trademark of things we do for no reason. Those are the low value added things, and getting them rid actually makes more time available and more cognitive space available for doing the right things for people.
I love that. Limiting choices. Yeah. Last question that I had, you've mentioned in the past how you're guided by a philosophy of continuous improvement, and you've even talked about that today. I'm really curious how this philosophy has influenced your approach to clinical practice, but then also leadership and also informatics.
Failure is permanent. We will lose. We will have setbacks. And flipping from that like a metric-driven success mindset to growth mindset, which is we want to improve, we will have errors, we will apologize, we will get better, we will learn from it and just move forward. So that culture needs that psychological and physiological safety. People have the money, what they need to feed the family, to be in a safe place. They have psychological safety that they will not be crucified or there won't be any punitive actions for sharing, for bringing out the problems and failures. So you fail, we work on it and we get better. That's all.
Yeah. And then just extrapolating on that, like what strategies have you found to be effective in creating that psychological safety for your teams and ensuring, like, is it just transparency and being upfront about it's okay to fail? And
transparency upfront, but biggest thing is the role modeling and sharing failures. I think one of the famous CMIO, C.T. Lin from University of Colorado, he has mentioned multiple things about a failure portfolio, a failure CV kind of thing. So mentioning self-deprecating is another form which could be on the fun side, but we can use it. So I think all these strategies individually could be used. But if the people who are reporting to you, working to you, looking up to you are seeing that what we say and do are two different things, it's not going to work.
Right.
People are way smarter than what we think.
Yeah. Well, awesome. Romil, just being mindful of your time, we're going to flip over to the Fast 5 lightning round. So 5 rapid fire questions for you, but so glad that we could spend the time with you so far. The first question we have is, what is your favorite book or book you've gifted the most?
Thinking Fast and Slow by Daniel Kahneman. I have gifted most to family, colleagues, and actually I know who has read it and who has not. That's the left brain data.
Right. Of course, you keep
That's
it in
really
the
funny.
spreadsheet, you track it. Yeah. Question 2, who is a person either dead or alive who you'd love to meet?
I would say 2. I can't decide on one. One is, again, Daniel Kahneman on the behavioral economist psychology side. Another person is Hans Rosling, the author of The Factfulness, and the Swedish physician who brought the data analytics or data visualization to the different level. His documentary Overpopulated or his work in the Gapminder kind of thing has been phenomenal. So both dead, unfortunately, and I would have loved to met them or worked with them or just being a mentee for them.
No, I love that. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
Super strength, super speed. I'll pass on all of those.
Okay.
I just want control for time, and if I can pause time and restart time or get more time in a day to do things, and that's all. So yeah, those are very big parts. That with them it comes, as Peter Parker's uncle said, the responsibility. So I don't want that big responsibility. I'm fine. Just having more time or stretch time for myself is all I need.
I love that. That's great. Question 4, what is something in healthcare you believe that others might find insane?
One is standardization. There are many colleagues, friends who will believe that standardization is not a good thing, and many will believe it's a very good thing, and we have a divide. As a country, we lose the advantage of having national guidelines like some of the European countries. So even 5 different societies fighting over what is definition of sepsis could be one example we can use, and other things like where people take different stands. That variation is good, but at some point we will have to agree to certain truths. A treated hypertension is better than untreated hypertension. A treating diabetes is the right thing than not treating it, kind of thing. So again, there are some truths which we have to follow. Another thing is placement of power of decision making. Healthcare is a different industry. It is compared to consumerism or example of food industry or KPIs or other things are met, but ultimately our goal or true north is that the people are healthier. They have less disease. We have need for less interventions. So that's a very difficult task, and that involves behavior modification. So where does that power rest? Is it the policy makers? Is it the payers? Is it the malpractice industry? Or is it that interaction between a physician and a patient, which is sacred, and is that shared decision making? I think we'll have to find that as a country. And sorry, it was too long.
No, it's great. That's fantastic. The last question that we have is, what is the last film or TV show you saw, and what did you think of it?
It was actually John Oliver's episode on RFK Jr., but if I mention something from that, it will increase your rating and I'll have a cancel culture for me or something. So I'm not going to go there. I watched a thriller which was Knox Goes Away from Michael Keaton, directed and acted, and in which he develops a Creutzfeldt-Jakob disease and is having, he knows that how his memory is going to work. And there was an interaction, 2 interactions, where he tells his paid companion that I will be leaving 1/3 of my assets to you. She doesn't understand it or understands it completely or hears it. Maybe there was a language barrier, maybe there was another barrier, or she hires some 3 people to split the assets 4 ways. So there is a scene where he has her on a gunpoint and asks her, what would have been your share if you were able to kill me? She says 1/4 because we were 4 people. And he says, I was offering you 1/3 already for doing nothing. So sometimes doing nothing is very important, and understanding of humans is very important.
Yeah. No, I love that. What a great analogy for life as well. That's awesome. Well, thank you so much, Romil, for spending the hour with us. That's a wrap, unfortunately, for this episode of The Digital Patient, hosted by SeamlessMD. You can follow us on Twitter at SeamlessMD. And if you like the podcast and you want to learn more, visit www.seamless.md. Romil, Dr. Chadha, again, thank you so much for spending the time with us and honestly sharing so much wisdom with our audience.
Thank you, Alan, and thank you, Joshua. And it's the simple philosophy. Only everyone can do everything. So we need everyone in this.
I love that.